The next speaker, I switch to English because René is supposed to understand me, is René Hendriksen from European Reference Laboratory for Antimicrobial Resistance in Denmark. And we asked him to give sort of a global perspective as well, so it fits to Tim's presentation. And I think he's going to tell us himself what he's going to tell us. René, the floor is yours.
Thank you, Bern Alvar. So first of all, thank you for inviting me and giving me the opportunity to talk about something that I think is really important, which is the transformation from the conventional surveillance into using whole genome sequencing. And as you said, that it links quite well with what Tim just talked about. So I have been working with capacity building, AMR, and surveillance for more than 2 decades, and sometimes you can actually get a bit frustrated why we are that slow in making changes. So that is more or less what I want to talk about in our EU and a more global perspective, talking around some examples from EU and Africa. So I would start the presentation first with a short disclaimer. So parts of this presentation is produced under the service contract with HaDEA, with the Commission. And some of the examples and details that I would mention about some of the EU projects are carried out in a reply to call for tender to provide services for the EC and also member states, just to have that straightened. So basically, I'll just jump directly into the subject. So I already heard Tim also explaining how important it is to really focus on the surveillance, and especially also in an AMR context. And I really think that it's about time to step up and strengthen the surveillance and outbreak detection. I really don't think there's a need for more data. I think that we have plenty of data that have shown our major problems, not only in Europe, but also globally. So Tim just showed the burden of AMR, and here is just a few examples that you probably all know much more about. The World Bank document that came out in 2014, showing again that it's especially the low and middle income countries that would be affected in the future with AMR. But we shouldn't forget that also in Europe we have problems. And I think I was a bit surprised also to read the Graham paper that was published in Lancet this year, showing that, of course, supporting the World Bank document, that Africa is, of course, the region where we see most problems. But again, Europe is also having definitely problems when we look at the burden of AMR and the level of resistance. So it's really time to take action, and that's what I mean, that we have enough data. We need really to take action and also do it in a harmonized way. So basically, there's nothing new in this. It was already communicated in 2015 by the former director from WHO, Maggie Chan, that came with a nice quote in connection with the 86th World Health Assembly. And basically it was formulated already at that time that AMR is in a crisis, and that we really need to do something about it because it threatens the very core of our modern medicine. And we need to do it in a harmonized and fashion on a global scale, because otherwise we would have a situation in the future where we couldn't really treat basic infections. So that was further described more in specific that there is a need really to look into to the surveillance part of AMR. and that it also goes a bit beyond just human health. There's also the contributing factors and the consequences like economics, climate changes, etc., that goes beyond the health. And because of that, there is really a need for a coherent, comprehensive, and integrated approach on a global, regional, and national level, and that this should be in a One Health context. So expanding beyond only looking at public health and veterinary health, but also the environment, etc. So again, this was back in 2015, and maybe I'm just a bit impatient, but I still think after 2 decades in this area that it really goes too slow. So it also takes me a bit to the next part. So where are we actually today? So we have in Europe, at least in our region, a quite comprehensive surveillance. It's maybe more harmonized in the food and the veterinary sector opposed to the public health. But when you look at the global scale, I'm not that positive. Even if we have a manual for global surveillance of AMR, the GLASS manual, it's not really there yet. The data is still fragmented. It's still a bit. There's plenty of gaps in the current surveillance on a global scale. And if we turn the picture to Africa, I think data is really still scarce in that region. And this is where we should actually maybe focus a bit as well in the Southeast Asia, because we know that these are already pointed out as disease hotspots. So this is really where we need also to focus. But again, our current surveillance is in many countries and also globally still based on phenotypic data. And it's actually methodologies that goes back decades. So have been in the area of building capacity for more than 20 years. I still see data, and this is just 2 examples. One is from the recent ELSNet EQA report, and the other one is from a UK aid Fleming Fund project in Africa, Equasia, testing the ability to do suitability testing in multiple countries in the African continent. And again, we still have an issue around quality. So again, when just looking at these 2 examples, we definitely see that even in hospitals in Europe, we have 95% deviations compared to the expected data, and it's even worse when we go to Africa. And I simply have a bit of difficulty to understand why we can't improve better, since this is an old technology. It's proven by decades. So why is it that there are still all of these deviations? So I was last week in Bangkok doing a training course for the Fleming Fund, and I was also there 20 years ago in '99 in association with a WHO course for the Global Foodborne Infectious Network. It was the same countries. We were teaching exactly the same thing that we did 20 years ago. So it also just showed that if we are not building the capacity and maintaining it, the technology and the quality would collapse. So it is really vital that we maintain capacity and keep the capacity intact over years. I also just had a call a couple of weeks ago with the ASLM in Africa, talking about exactly the same thing. And basically I asked the question, why is it that we do not have high quality suitability data, and especially in Africa? And the question was, there's no money in it. It's not really sexy. So there's not an industry around it. It's just AGAR, it's DISC. And that is maybe one of the problems around it, that it's so basic that nobody actually wants to pay attention to it. But again, when you go into the training and you want to explain scientists, clinicians about suitability testing, it's not that trivial. There's actually a million of different rules to apply to different drugs when reading them. And that is the reason why we actually see all of these problems in conventional testing. So we have also for the last 10 years talked about the paradigm shift in surveillance, that we should all go genomics. But again, I think it's really a nice illustration here from Nature Reviews, but that's showing how we can decrease time and really use the same technology for a lot of different species. And yes, it looks really nice and it also works. But again, the technology have not moved into public health and animal health and the food sector yet, not on a global scale and only limited in Europe. And this is after working for genomics in 10 years in academia. So I think that genomics have moved for the last 10 years, but it's mainly been in academia. So there is really a need to move it from academia into public health, veterinary health, and the food sector. And that is one of the limiting factors right now. So again, when we look at some of the analysis that have been, or assessment that have been conducted recently, we can still see that if you look at the labs, countries that would actually have integrated surveillance in routine in Europe, we still see that it's limited to less than 10 countries. I know this is a bit older data, but it's still basically the notion that there is these 10, 15 countries that have implemented whole genome sequencing in public health, animal health, and in the food sectors. And when we look at how many labs or countries that actually submit data, it's still, the majority is still coming from the US and the UK, where when you look at the numbers, you would actually be surprised to see how little data that are submitted by public health, veterinary, and the food sectors. So again, this underpins that it's not really been rolled out yet for AMR surveillance and outbreak investigation in public health and in the food and the veterinary sector. But again, I think there's still light at the end of the tunnel, even if I'm a bit critical now. So as I indicated in the disclaimer, SSI and DTU have applied to a call of tender. And basically, there is now, let's call it a three-step rocket that actually would try to build the capacity. So I'm not going into details that much of what is being built, but just to kind of put a light at the end of the tunnel. So as you might know, that the Commission have launched the HERA incubator a couple of years ago, mainly to build preparedness and for the COVID situation. So basically, I put this as a first stage of the rocket and try to see it more as a phase where we build instrumentation. So basically, the HERA incubator was meant to provide sequence platforms for mainly public health laboratories in Europe. The second stage of the rocket is the two projects that have a bit of awful names. One is called the European RefLab CAP, where the other one is Forward AMR RefLab CAP. So these are two projects quite alike. I'll come back to that, but actually building capacity still in public health laboratories in Europe. And then the third stage is actually addressing some of the needs that we have identified in these two RefLab CAP projects. And those would be addressed in another project where there was a recent call text. the call text was more about genomic epidemiology and bioinformatic training. And this is where there's a great opportunity to further build upon what is already elaborated and coordinated in the first and the second stage. And I'll come back to a bit more of the details. Opposed to what we have in Europe, there's also quite a number of projects in Africa also trying to build exactly the same. So when we in Europe think that we are light years ahead of the rest of the world, yes, in academia, but not in public health, veterinary health, and in the food sector. So I think actually that what I have seen in Africa and in Asia is that we are basically in the same level in Europe as we are in the other countries, which is, in my opinion, a bit sad. And again, when you look in Africa, there have been really, it's been really crowded. So the Gates have funded a large project in Africa called the Pathogen Genomic Initiative, mainly focusing on COVID. And this is still ongoing. And there's also other projects. So I'm leading another UKA Fleming Fund project called SEC Africa, trying to build more surveillance around AMR opposed to COVID. We did also COVID, but the main focus was AMR. And then there's another project called SARA that was funded by Institut Pasteur, and this is also ongoing. And there are other projects that I might not know about, but anyway, there's still momentum in Africa trying to build the surveillance for AMR surveillance based on whole genome sequencing. So going a bit back to the second stage of the rocket that I was referring to in EU. So just to give a bit more perspectives around those projects. So these are 4 years projects. We are already 2 years into it. It provides training, quality, external quality assurance assessments, networking activities, and mainly to build a public health reference laboratory functions to focus on local, regional, and national levels. And the idea is to enhance the validity and the accuracy of surveillance data for AMR in order to inform concerned actions against AMR. And this would allow us to better detect and control cross-border threats, as we have seen and heard about in also the symposia with the burden of AMR, that it's not only a European problem, it's a global problem. So basically, the two projects that I already talked about are very similar in the structure. The EUROGEN would focus on priority healthcare associated infections, opposed to the Forward AMR project that focus more on Salmonella and Campylobacter. And basically, two of them have the vision to strengthen coordination, support, and capacity in the Public Health National Reference Laboratory for the 5 core functions for serving as a national reference laboratory. So this is basically to strengthen the laboratories. So the more specific objective is to support the operation of the National Reference Laboratory. And this is by providing capacity building activities like the training, quality assurance, also site visits in some of the countries. But it's also to validate detection methodologies in compliance to the new EU case definition. So when we look at the two projects, one would focus on the carbapenem-resistant Enterobacter, so the CCRE, in specific E. coli, Klebsiella, Acinetobacter baumannii, and Pseudomonas aeruginosa, opposed to the smaller project, which is still on Campylobacter and Salmonella. And this is mainly for surveillance and outbreak detection in an AMR context. So basically, there are certain specific capacity is. And then also in the context of this talk, it's to modernize the diagnostics and molecular typing within European public health laboratories. So opposed to that, we have a similar project, as I indicated, in Africa, where we are now moving into a second phase of SEC Africa. So this would be a continuation of data generation. We have already, for the last 3 years, sequenced more than 18,000 genomes of various species in the 5 regional centers that we have created, and I'll come back to that. We would also continue to do training, to train more health professionals in the continent. We would develop professional and leadership within surveillance, building on whole genome sequencing to strengthen the AMR surveillance. And then we would work on also phasing over this project to its rightful owner, which would be the African Union, the Africa CDC. So I'm going to Ethiopia in 2 weeks to discuss the future phase over of the project. So we would be embedded as a component in the Pathogen Genomic Initiative, which is also now going to focus on AMR, since now COVID is being less a burden in the continent. So having already the capacity for COVID, it's logic to the transition from COVID into AMR, and that is what we would like to discuss more details in a few weeks in Addis Ababa. So we also want to, we also want to further expand the capacity of sequencing for AMR surveillance in Africa by setting up sentinel sites, surveillance sites, and focusing more on the ONT technology. So these are some of the future expansion. We also want to focus more on specific pathogens. So in the beginning, it was a bit more ad hoc reference services sequencing these 18,000 sequences, but in the future we want to focus on specific pathogens like E. coli, Klebsiella, Staph aureus, non-typhoid Salmonella, strep, pneumonia. And this is also to maybe prepare a bit for some of the other donor grants that have talked quite heavily about building the silver bullet for AMR, producing AMR vaccines. Then you can believe it or not, but if you don't have the data, it would never fly. So this is also some of the focus area. And then, of course, as I said, extend the capacity in collaboration with PGI and SARA in Africa to other countries, to sentinel sites, and then do much more in-person training. And of course also further extend the capacity in the regional sites that we have built. So basically in the first phase of the project where we build the referral system, so now actually building more sentinel sites that can feed into a referral site. So that is part of the vision also for Africa. Very similar to what we try to address in Europe. So basically, in the third stage of what I've talked about in EU with the genomic epidemiology bioinformatic training. So in this project, as I said, it's trying to focus on some of the needs and limitations that we have encountered in the 2 other RefLab projects. So I think basically the structure of this new project, only focusing on public health laboratories in Europe, there's a great opportunity to leverage these activities also to an Africa context, because what we need in Europe is exactly the same as we need also in Africa. So some of the tasks in the future GenEpi BioTrain project would be to set up some face-to-face workshop, bridging the gaps in bioinformatics. So basically to invite the lead bioinformaticians in public health laboratories in Europe, bring them together in workshops, and then simply build capacity in different areas of bioinformatics. In workshops that will be carried over in 4 years, starting with 1 week's courses, 2 weeks courses, 3 weeks courses, building the capacity with the same people. Ideally up to 100 bioinformaticians in Europe. If these actually exist, this is definitely on a more theoretical level. At the same time, also have face-to-face workshops, so interdisciplinary genomic epidemiology and public health informatics training. So basically inviting epidemiologists and microbiologists to also be aware about sequencing, but from a more microbiology and epidemiology point of view. And then later set up training and exchange visits of the bioinformaticians so they can see how is bioinformatic analysis being conducted in other European labs, so they can learn from other workflows. For instance, it could be that there would be bioinformaticians from Poland that would visit RKI, see how AMR surveillance for multiple pathogens have been set up in Germany. And vice versa, that also German bioinformatician would maybe go to France and see how it's been done there. Later on in the project, there would be face-to-face trainings on genomic epidemiology. So basically form country teams of both microbiologists, epidemiologists, and bioinformaticians, and then force them to learn to work together and train them in doing outbreak investigation, surveillance exercises. And then later on in the project to set up monthly virtual training simulations, having these country teams to work together. So I think this is definitely something that we need if we want to really move whole genome sequence-based AMR surveillance and outbreak investigation forward. So I think there's also a great opportunity now to take the same concept and really roll it out in an African context with either PGI, the Fleming Fund, etc. So these are some of the perspectives that we look for in the near future in Europe and in Africa. But again, now as Bern Aloir mentioned in the introduction, I'm also representing the EUL for AMR. And again, I think a bit, are we losing momentum in this sector? So opposed to public health, we actually in the veterinary and the food sector, all of the surveillance is harmonized, standardized based on hardcore legislations that stipulate exactly how to do all of the surveillance. And already in the latest version that goes back a few years, we opened up for an alternative methods that whole genome sequencing could also be applied in an AMR surveillance. But again, I really fear that we are losing momentum because we do not in the food sector and the veterinary sector have the same projects as I have just described with the 3 rocket step in public health. So basically in the food and the veterinary area, we are still depending on our governments, our institutions to purchase the instrumentation for sequencing, set up workflows, etc., etc. So I am actually a bit afraid that we are losing the momentum in this area, which were just a few years ago in the forefront, at least in Europe, if we ignore academia. So again, I think that from a personal perspective, some of the major challenges and barriers that I have encountered are still that we need more training. The bioinformaticians, now I have visited a number of countries in the RefLab CAP project, and still a lot of the bioinformaticians need to know what software to use. And this is also in order to allow them to build more high throughput workflows for basic analysis. So basically they need to know how to program, how to do interfaces between different software, etc. So this is greatly missing. We also need to have the microbiologists and the epidemiologists know how to analyze genomic data. So I've been there as well, where I have been handed over a phylogenetic tree, where I asked the bioinformatician, can I actually trust this tree? And the bioinformatician said, do you want another tree? So again, when is a tree true? So that is also some of the things that we need to train. Then again, we have encountered huge problem with procurement of instrumentation and reagent. So basically after COVID, there's a huge shortage of filter tips in Africa, but also in Europe. And again, procurement of instrumentations and reagents, kits, it just takes forever to get. And why is it that scientists in Africa have to pay much more for instrumentations in Africa than in Europe? So there is really also some equality that we have to address. Then we also need to look at the engagement with the ministers. Again, there's a huge lack of country buy-in, not only in Africa, but also in Europe. So why is it that the Minister of Agriculture, Minister of Public Health do not support national reference laboratories in a greater way to equip them and make sure that they have resources to also take the transition from phenotypic surveillance of AMR into a genomic? And then we also need, of course, to focus on also the high turnover of staff. So again, training of bioinformaticians would really go directly into private industry because of higher salaries. So there's a great deal of brain drain in both Europe and in Africa. And then we, of course, also, as I said, need to ensure that the ENILs have sufficient funds for both staff, reagents, etc. And coming to an end, from my future perspectives, I think that there is a realistic alternative to conventional phenotypic susceptibility testing. Again, as I said, for more than 20 years, I have seen basically phenotypic surveillance being inadequate. And I think that genomics have been assessed and it's been proven by academia and research. So it's just to move further on, and we need to really communicate about the added value in genomics. And then we definitely need to ensure that there is country buy-in, so we need to have it prioritized by governments and supranational organizations, also by EU. And then again, we need to ensure that we have sufficient data, also in terms of providing data for a silver bullet for AMR vaccine, if that should be feasible. But again, we have to acknowledge that a silver bullet is just an immediate cure. It would not resolve our problem with the problems in AMR and the burden of it, as also Tim elaborated around. I know that I have talked also earlier on about metagenomics, that this is a promising technology. I really still think that this is also the future, but I also come to the perception that we need to walk before we can run, and especially in working with the public health laboratories in Europe and in Africa, I definitely see that there's still a long way to go before we can actually move metagenomics into standard procedure in a non-academia settings. And then, of course, we need to address the monopoly that major companies have right now, and I'm talking about the sequence companies, and we need to overcome the huge barrier in procurement. So again, there is still some limitations that do not allow for the full rollout of the AMR surveillance globally. So I think that was what I had in mind. I hope you see some of the perspectives as well, because I definitely think there's, as I said, light at the end of the tunnel.